Okay. Hello, dear ladies and gentlemen, dear colleagues. Welcome to Second CUPID Annual Conference.
Recording in progress.
Of lives of people with intellectual disabilities in the European Union and beyond. Among the European intellectual disabilities population, many cancer diagnoses are underdiagnosed. One study published in February this year has shown that individuals with IDD are more likely to die from breast, lung, and colorectal cancer than the general population. Although it is known that individuals with IDD have higher overall mortality rates than the general population, the cancer survival findings are stark. The Council of Europe Disability Strategy from 2017 until 2023 recognized health systems' failure to engage with and include people with disabilities. CUPID establishes active working partnership with academics, researchers, non-governmental organizations, carriers, people with intellectual disabilities, and policymakers. Some of CUPID objectives are creation of database of experts to assist in the planning and conduct of primary research in cancer prevention in the intellectual disabilities populations, involve early stage researchers, young researchers, and researchers from less research-intensive countries in the CUPID network. Develop and establish both short continuous professional development and long-term programs in the emerging areas of interest developed by the activities of the CUPID network. Foster collaboration between diverse networks of researchers, including co-researchers from the intellectual disabilities community that will build capacity to develop joint research initiatives, etc. Today, on this occasion, we will hear interesting topics about reflections on the CUPID WG1 group training school in Prague, this September, systematic review and meta-analysis of cancer prevalence and incidence in adults with intellectual disability, influences on the uptake of colorectal cancer screening in people with learning disabilities, a systematic review. We will see the annual report of Working Group 4. And finally, we will hear more about cervical cancer screening among persons with intellectual disability. I would like to ask all of you to turn off your cameras and microphones during this web conference. Also, you can send your questions and comments in the section Q&A or in the chat, but we prefer Q&A. Each presentation should last 8 to 10 minutes. I will ask the presenters to present on time. And at the end of all 5 presentations, there will be a question and discussion session. And if some of you want to join us with audio and video, please just raise your hand. If you don't want to appear with camera, you should send your question in the Q&A. So I think that all the rules are understandable. Now we have around 45 participants. I hope we will have much more. I hope that you will enjoy this web conference, the second Annual Conference. Last year on the 15th of November, we also have conference. All these web conference will be streamed on our CUPID YouTube channel. Is streaming now, and also there will be photos. So if you don't want to appear on our social media or our website, please don't turn on your cameras. Now, ladies and gentlemen, I'm inviting first speakers, Dr. Margaret Denny and Dr. Oliwia Kowalczyk, the leaders of Working Group 1, to take the floor. The title of their presentation is Implementing Effective Cancer Preventive Approaches and Modalities Tailored Specifically for Individuals with Intellectual and Developmental Disabilities. I hope you will, all of you will enjoy in this presentation. And please, dear colleagues, Dr. Margaret and Dr. Oliwia, start your presentation.
Good afternoon, everybody. Am I on? Good afternoon, everybody, and thank you for joining us today for our presentation. In the absence of the chair, Dr. Suzanne Denieffe, who's actually indisposed and doing, she's at the conferring ceremonies in the local university, in her own university. So on behalf of Oliwia and I, we will present her section. Thank you. So we would first like to start by extending our sincere gratitude to the people for their valuable contributions to our training school in Prague. And the names, you can read them all there. They were instrumental in making this training school a success for us in Working Group 1. So what we plan to do today is do some reflections on that training school in Prague in September. These reflections highlight the strengths and areas for growth and the importance of ongoing collaboration, co-production approaches for improved health for people with intellectual and developmental disabilities in relation to cancer prevention. Working Group 1, the recent training school on cancer prevention held by the Cost Action CA 21123 team in Prague offered a unique opportunity to address significant gaps in healthcare cancer prevention education. This training aimed not only to increase awareness, but also to empower people with intellectual disabilities, their support persons, and health professionals through accessible and inclusive resources to learn about cancer prevention. What we'll focus on really are the success and positive takeaways initially. Three main areas we looked at. Inclusivity, co-production was at the core. By creating easy-to-read materials on cancer prevention and prioritizing meaningful engagement, accessibility, and support, the event ensured that all participants, including those with intellectual disabilities, could engage meaningfully. The development of a tailored educational tools demonstrated a commitment to breaking down communication barriers that often impede people with intellectual disability, their understanding of health-related topics to cancer prevention. 2, we looked at the collaborative learning and co-production. The training school adopted a collaborative approach, welcoming contributions from both people with intellectual disabilities, online participants, invited speakers, and those with lived experience of cancer. Live narratives from participants who share their personal cancer journeys brought a profound sense of empathy and relevance to the sessions, deepening the understanding for all. And 3, we looked at feedback-driven improvements. Participant evaluations provided insights into the strengths and challenges of the training school, positive feedback on engagement levels and content clarity affirmed that the resources at the training school were indeed well received. Additionally, feedback on logistical aspects highlighted areas for refinement, ensuring even more smoother future events. So I suppose the feedback highlights the importance of tailored cancer prevention program interventions for people with intellectual disability, the significance of allowing people with intellectual disabilities to express their understanding was pivotal, and the need for inclusive, egalitarian health services. And the limitations were truly identified of traditional communication patterns. So enhanced tailored communication, the training school underscored the need for specialized communication strategies that extend beyond traditional methods. Cancer prevention concepts can be complex, especially for people with intellectual disabilities. Future training should explore more diverse communication aids like visual aids, simplified language, and more interactive training schools. Sustaining engagement. While the training school event saw a strong turnout of both in-person and virtual attendees, maintaining momentum and ongoing engagement will be essential. Regular check-ins, follow-up resources, booster sessions, micro-credential modules being developed, online forums could help keep participants connected and invested in applying cancer prevention strategies in their daily lives. The outputs in terms of, at the moment, we're looking at an online booklet for all attendees organization based on the training school, which will be shared by Professor Vladimir, and the training materials for future micro-credential modules on cancer prevention, publications relating both to Working Group 1 and indeed the co-production process of the training school. And of course, the screening tool that we did across Europe will be evaluated in relation to cancer prevention in various countries, and delivery engagement and satisfaction on the evaluation that we carried out as a result. Now I would like to hand over to Oliwia to finish the presentation. Thank you.
Thank you, Margaret. I'm glad to continue. And if to save time, may I ask you to click the next slide?
Yes.
Yeah, no, right. So evaluating the impact of the training school of knowledge retention and behavior change over time would be a valuable guide for us to organize future training sessions. And pre-evaluated feedback provides a favorable picture, but additionally, we would like to note that understanding the extent to which participants can apply what they have learned to real-life situations would influence the long-term effectiveness of such training sessions. Next slide, please. The training school highlighted the issue of the disproportionate impact of cancer on people with intellectual disabilities, which is an often overlooked fact in mainstream healthcare. Therefore, based on our experience, it needs to be said that the alignment of cancer prevention strategies for this group is, in addition to a public health issue, also an equity and social justice issue. The inclusive approach of our training certainly indicates that health education must be adapted to the diverse needs of all populations, particularly with regard to cancer prevention education. The next slide, please. Our training school has undoubtedly been a huge success. So in our future plans, we will base our activities on the lessons that we have learned from the evaluation. The project can increase its effectiveness and inclusiveness by promoting collaboration in interdisciplinary teams, incorporating co-production methods, creating more adaptive educational resources, and by improving evaluation methods. Additionally, fostering partnerships with other organizations focused on people with developmental and intellectual disabilities healthcare will also have an impact on supporting our efforts in the next phases of the project. The next one, please. The CUPID Training School in Prague was a promising step forward in educating people with intellectual disabilities about cancer prevention. This initiative certainly embodies a compassionate, evidence-based approach to cancer prevention education, while addressing both the unique needs and untapped potential for this target group. In terms of future plans and activities, continued collaboration and co-production approach and a commitment to inclusion will go a long way towards a vision where everyone has both the knowledge and the right tools to lead healthier lives. And to sum up the last slide of my part, the reflections presented today highlight the strengths and opportunities for development of the CUPID Training School, while demonstrating a long-term vision of inclusive, accessible health education for people with intellectual and developmental disabilities. Thank you for this part, and I will ask you, Margaret, to continue with the
There are just some pictures of the event, our lanyards, our training school schedule, and you will see those on the site, and the registration for virtual session, the lived experience delivered by Dr. Suzanne Denieffe and Dr. Sinead Foran. We had in attendance 43, and virtual participants we had 51, and these were just the 3 days of the workshop. Okay, thank you.
Thank you very much, both of you, dear ladies and colleagues. It was really amazing training school in Prague. I was the witness of it, and probably if there is one question we can go with now, if there is from the audience. If no, at the end, I hope. It was your tremendous work which you have done in the last year, and my congratulations to you as a vice chair of CUPID for your work you have done in, especially in the training school and in the networking and in your efforts to bring 6 or 7 people with intellectual disabilities from different European countries. And it was additional value of the CUPID project, in my opinion. Thank you. I cannot see the raised hand or some question in the chat or session. Okay, thank you very much. I hope you will stay with us until the end of this web conference. Now I will go to the next speaker to announce the next speaker. Our next speaker is Dr. Martin McMahon. Sorry if I missed something in pronunciation of the surname. His title is Systematic Review and Meta-Analysis on Cancer Prevalence and Incidence in Adults with Intellectual Disability. Okay, Dr. McMahon, you can go.
Thanks, Vladimir. Can everybody hear me okay?
Yes.
Good. Okay. So
we see the presentation. Everything is well.
Perfect. Brilliant. Okay. So delighted to present here today, looking at the prevalence and incidence of cancer among adults with an intellectual disability. So I've got 10 minutes to get through this, so it's quite heavy. So I'm gonna go over it, I suppose, as detailed as I can, but looking forward to any questions you may have afterwards. So when we consider the aim of this presentation is to bring together the available evidence on the prevalence and incidence of cancer in adults with an intellectual disability. I suppose, you know, throughout CUPID and throughout our work in different areas, we talk around, I suppose, how common is cancers in this population. And I suppose when we consider the general population, cancers, the prevalence and incidence of certain cancers and cancers more broadly are well documented. Not so much for people with an intellectual disability, but we are starting to see emerging evidence with increased cancer likelihood. So people with intellectual disability more likely to get cancer. When they get cancer, more more likely to die from cancer. And I think Amina is on the call here. So Amina's recent systematic review looked at there may be a different syndromic profile for people with an intellectual disability. And we're starting to see from the Canadian study, I think that Vladimir talked around earlier in his introduction, we're starting to see that cancer is occurring at younger age in this population. So there's specific cancer risks and outcomes. So people with an intellectual disability more likely to be diagnosed with cancers when it has spread, more likely to have certain types of cancers, and are more likely to be diagnosed in emergency presentations when I suppose the chances of having curative treatment for survival are less. And then we're starting to see the Swedish study, starting to see that there's a certain profile with the types of cancer that people with an intellectual disability are given. But the current issue is that despite all this, the data on the prevalence and incidence of cancer in people with an intellectual disability is inconclusive. So I suppose what we've done here and what I'm going to talk around is we undertook a Joanna Briggs Institute Prevalence and Incidence systematic review and meta-analysis to try and document and bring together how common cancer is through looking at prevalence and incidence. And these are very important reviews because what they do is they try and bring together the disease burden and trends in different populations. So what we did, so we had a protocol that was published. I think that was reviewed by Trine, who's also part of the CUPID cost action, and that was published. And we followed, as I said, the JBI systematic and review meta-analysis and the PRESMA-P guidelines. And we done very detailed searches on IMBASE, Medline, Sinal, Ultimate Psych for Web of Science, and also all the grey literature. And we had an information scientist as part of the review. So we looked at observational studies for adults over the age of 18 who've got a diagnosis of intellectual disability and potentially hold that thought for maybe some of the discussions later on. And we looked at the outcomes where the prevalence and incidence of cancer or any types of cancer or subtypes of cancer in people with an intellectual disability. For data extraction, we had a pre-designed form that we piloted on 5 studies, and that's published on the Open Science Framework with a DOI. And with quality appraisal, we used a modified JBI critical appraisal checks list with a maximum score of 18. We had disagreements that were resolved through a third reviewer, and the meta-analysis tools. We used MetaXL, which is an application in Excel, and we used the dissimilar proportional methods for random meta-effects analysis. For heterogeneity, which was a real problem with this study, we measured through the Q statistics and I-squared index, and the study was also registered with Professero. So getting on to it, what do we find? So out of 3,500 studies, only 17 studies met the inclusion criteria. So for prevalence studies, 5 studies used odds ratios, and 4 studies used counts and overall proportionate or population level data. For the incidence studies, 11 studies used cancer counts and 4 studies used odds ratios. Where did the evidence come from? As you can see here, typically from high income or medium high income countries. We can see across the 17 studies, 3 come from the UK and 2, which was the highest. And then we can see other studies like Germany, the Netherlands, Sweden, etc. 1 study. These are the overview of included studies. I'm not going to go through these in details. This publication, this has just been written up and submitted currently for publication. Typically, actually, when we applied the quality assessment criteria, most studies had actually a high level of quality insofar as they met the aims and objectives of what was set out with regards to the parameters for the assessing quality appraisal using the JBI modified score. So getting into, I suppose, the nuts and bolts of it, what we have here is that, you know, this shows mixed results here, looking at the prevalence and incidence of prevalence of cancer among people with an intellectual disability. So what if we take a look on the right-hand side, we start to see here, you know, higher prevalence for breast and colorectal cancer, and that's the Canadian study that Vladimir talked around a few moments ago. And if we take a look at, I suppose, a study that I undertook in 2021, we start to see a lower prevalence here. So what we're starting to see is, I suppose, a bit of a mess in a sense with regards to the prevalence of cancer in people with an intellectual disability. But what we have here is we have, you know, the high, you know, I-squared here index. So that suggests that there's significant or substantial heterogeneity across studies. So what does this mean? That the prevalence varies significantly. And that's what we found with all our studies. We take a look at, that was the study then, if we take a look at that used odds ratios, we take a look at the counts, we start to see here The Jankar study going back to 1990, we start to see an outlier here. Again, with regards to the prevalence, and again, prevalence varies widely. And again, this is very much due to the heterogeneity heterogeneity of studies. We removed the Jankar study, but we start to see no discernible difference either. So what we're seeing here is you need, to interpret these results with extreme caution. We look at the incidence here again. If we take a look at the LAND study to the right-hand side, it's got a higher incidence, but the estimated incidence here is typically around 2%. So we can see there in the bottom right-hand corner. But again, we've got really high levels of heterogeneity, and also the confidence interval. We start to see, so we're starting to see it's not statistically significant. So we start to see then again that even though the incidence is around 2% of point prevalence here, there's considerable heterogeneity among studies. We removed the LAND study. That was pretty much as we see in the previous slide. They're up at 0.7. But we start to see then that even though it's still, there's still a significant heterogeneity across studies. We took a look then at looking at cancer in incidence and gender, and there was 4 studies, that were included that there was not information available on being female or male. But what we start to see here is the incidence for cancer in females with intellectual disability. It varies across studies, but there's a slight but non-significant increase in the incidence. So a pooled OR, as we can see in the bottom right here, odds ratio of 1.7. What we see here is the difference is the heterogeneity is at 0%. So even though we're not seeing a significant difference, what we are starting to see is that, there's less heterogeneity across studies, which demonstrates that there's a level of robustness. When we take a look here, take a look at cancer in males, we see the incidence of cancer in males and people with an intellectual disability varies widely across studies, but there's a slight and non-significant decrease in the incidence of cancer in people with an intellectual disability with a pooled odds ratio of 0.93. The heterogeneity, again, of 0% using the I-squared index indicates consistent findings. So we're starting to see, even though it's not significantly significant, we're starting to see when we look at across gender, we're starting to see that the findings are more robust. So what does this mean? It means, we've attempted to provide an overview of cancer prevalence and incidence in people with an intellectual disability. The findings, I suppose essentially they will be presented in a narrative summary because the high levels of variability and heterogeneity the high levels of heterogeneity in studies, we need to interpret it with caution. So some studies are suggesting an increased prevalence for certain cancers, like colorectal and breast cancer in one of the Maher studies, and other indicating a lower or no significant differences. What we're starting to see with this obviously analysis is that the pooled analysis for prevalence somewhere is in the region of 2 to 7%, but as I've said, that needs to be interpreted with caution. When there's a lack of significant difference in cancer incidence between the intellectual disability population, the general population, with pooled odds ratios of around 0.7 for females and 0.93 for males. So what does this all mean? I'm at 9 minutes and 30 seconds. It means that there's no consistent pattern. However, there's slight gender differences starting to be observed, with this non-statistically significant, and heterogeneity suggests with regards to gender that these may be, it's a trend that we should start looking at. There has been a Scottish study published since we've looked at this from Laura Ward and has found that adults with intellectual disability were less likely to be diagnosed with cancer, but disproportionately more likely to die from cancer. We've actually put the Ward study into the meta-analysis that I don't have the results today, and it doesn't show any difference to the results that we are seeing. So it's still the same trend. So these findings highlight the importance of a universal approach towards the standardization of data collection. That's something we really need to consider, from CUPID moving forward, regards to with regards to studies that we are undertaking, we are asking questions and collecting cancer data in different ways. Identifying people with an intellectual disability is a real challenge. We need to look at the longitudinal study with representative samples, but then look at the data linkage in these samples and data integration. Limitations of the studies, we said heterogeneity of study design. So all the studies are looking at things in a different way. There's sampling bias and representative. So some of the prevalence studies, the earlier ones, are in smaller samples. Data completeness. So for example, we're looking at, gender, so male versus female. What we're starting to see there is that some studies, aren't reporting on it. Geography, you see in regard to presentation of the geography, we've got typically the findings relate to countries, higher income countries, and also some of the studies are quite dated and old. So I'm going to finish my presentation there, and thank you.
Thank you too, Dr. Martin McMahon. You're one of the leaders of the second working group, and it was a short but very comprehensive systematic overview, and also the people who are interested in your work, they can find a lot of publication in this field from you. I can see one question here in the chat. Probably you can see also what specific risk factors have been identified that might contribute to the slightly higher incidence of cancer in this population. Are the healthcare or the access to healthcare and maybe socioeconomic factors influence the incidence of cancer and the higher risk of death in individuals with intellectual disabilities despite the slight difference? Please go on.
Yeah, I said, look, it's a brilliant question. We don't typically know. The risk factors are probably the same. They will be the same for people with an intellectual disability as they are for the general population. Lack of access to healthcare based on the socioeconomic factors that you identified there will mean that people maybe aren't being diagnosed with cancer. So some of the work that we are doing here, we're seeing that people with an intellectual disability are dying from cancer, but we're only seeing cancer showing up in their death certificates, but they would have had no diagnosis when they were alive or being diagnosed in emergency presentation. Yeah. Peter, yeah, good question. If they're measured differently in the included studies, is it helpful? Yeah, Peter, I think that's the question. This is really much shown how much you mess the data is in. That just is just to present them in this way at this stage. But yeah, we're doing it separately. I think for the publication that we're writing up, it'll be like a narrative summary essentially, because yeah, is it helpful with the high levels of heterogeneity also? Yeah, so I think that's a really valid point, Peter.
Okay, thank you very much. We must go on with the next speaker. So please, for the other interested people in this issue, please save your questions and comments for the end of this web conference. Now I'm inviting Professor Peter Knapp from UK, who will present influences on the uptake of colorectal cancer screening in people with learning disabilities, a systematic review. One more systematic review. Please, the floor is yours.
Thank you. Can you see my screen?
Yes, please go on.
Okay, thank you. Thanks very much for the introduction and the opportunity to present this work. So I'm presenting this on behalf of 4 co-authors, all from the University of Central Lancashire. I'm from the University of York, and the work was supported by the UK National Institute for Health and Care Research undergraduate internship program. So Pritika Sagar and Muskan Agarwal are undergraduate medics at University of Central Lancashire. I can't seem to. Oh, hang on a second. Can't seem to scroll down. Sorry, let me just.
Probably you should try with the button page down, or
Yeah, let me just stop sharing.
Now you turn off the presentation.
Right, I just have to. Okay, let's try this one. Okay, I have to try this. So the background is that colorectal cancer is progressive. It's a disease that's staged 1 to 4, and the 5-year survival after diagnosis is greatly affected by stagic diagnosis. So, for example, with patients who are diagnosed in stages 1 and 2, then the 5-year survival rate is around 90%, but it plummets really to 10% of patients who are diagnosed at stage 4. So it has a really significant impact on life expectancy. Colorectal screening in the UK, and I don't have the position for countries around Europe, but in the UK, that we now use the FIT test, which is sent to people aged between 55 and 74 every 2 years, and in fact will reduce to the age of 50 very soon. And what happens is you receive a letter a few weeks in advance to say you're going to get a kit, and then a kit is posted to your home address, and you have to take a small sample of stool, and then you post it back, and then you get the result a couple of weeks after that. And if you're shown to be at risk on the basis of the test, then you're offered a colonoscopy. And the latest data we have on the UK population uptake is 69%. So it's a good uptake across the population, but quite significant variation by geography and socioeconomics. Some of the background here about cancers in intellectual disabilities, actually Martin has already covered, so I won't go into lots of detail here, but what we know is there's a pattern of people with intellectual disabilities being diagnosed late, having majority of cancers diagnosed at later stage cancers, having cancer diagnosis as an emergency, both of those associated with poor prognosis. And then higher rates of colorectal cancer being diagnosed as a metastatic disease compared with the general population. Risk of death is higher. And some work by Martin Kuipers and others looking at, in the Netherlands, people with intellectual disabilities receiving less cancer care. So quite a negative picture around the expectation of people with intellectual disabilities and cancer. We did a systematic review looking at the 3 national screening programs, bowel cancer and cervical. I'm just reporting the bowel cancer results here, but we did a single search. So we just used what I would say was good practice in systematic reviewing. Protocol was registered on Prospero. We searched multiple databases. We were looking for studies reporting primary data on the reasons for attending for screening or not. So that's data from people with intellectual disabilities, their relatives, support workers, and healthcare professionals. So primary data, whether that's reported in qualitative or quantitative research. And we set a cutoff of the year 2000 for inclusion. We used dual independent screening, so 2 people doing the ratings and then agreeing by consensus. We did data extraction, dual independent data extraction and quality appraisal. And we had just under 9,000 hits. And for the bowel work, we included 10 papers. So just three that were specific to colorectal screening in people with intellectual disabilities, and then 7 that related to any of the screening types. And the results were these. So in summary, we just only have these 3 studies about people with intellectual disabilities and bowel cancer screening, one from the UK, one from the US, and one from Canada. So from the one from the UK suggests that lack of lower screening uptake of colorectal cancer was in this population based to a lack of knowledge, a lack of confidence, and fewer intentions to be screened. So it wasn't about people intending to be screened and then not doing it. Actually, there were less intentions to screen. The Canadian study looked at fecal occult blood, a different method of identifying bowel cancer screening, and that suggested, based on quite a big data set, that the FOB test was more likely to be undertaken in people who were older, who were female, who lived in more affluent areas, who were enrolled with a family doctor, and were bigger users of healthcare healthcare services. And then the last study was a small sample study of 40 people with intellectual disability who'd attended for colonoscopy, suggesting really poor levels of preparation. It's a colonoscopy. You have to do significant bowel prep for the process to be effective. And there was poor levels of preparation in people with intellectual disabilities, and that resulted in failed examinations in a number of them, and actually a delayed surgical resection in 2 of the patients who'd attended. The 7 non-specific papers reported effects of practitioner attitudes and practitioner risk benefit assessment, procedural fear amongst people with intellectual disabilities, a lack of knowledge, tests not being ordered or not used. So for instance, when people had an annual assessment, there was a recommendation for them to have a cancer screening test, but it wasn't taken up, or it was sent and then refused. And then things like transport problems causing lower uptake. There was one study that suggests there were benefits of having a health advocate as a way of increasing screening uptake, and those were all in the general studies. So overall, quite quick whiz through this, there's a real lack of research in this area. So we found no studies reporting the effects of the uptake of FIT, which is the test that's used in the UK amongst people with intellectual disabilities. And I think this screening method is being used and being used in other countries, and we need to know more about why people with intellectual disabilities do or don't take up this opportunity to get screened. Thank you.
Thank you very much, Professor Knapp, for your short and very, very good analysis of and making systematic review of all those studies dealing with cancer of colon. So is there any question now? I can see in the chat from the audience. In this moment, we have 56 participants on this annual conference. Yeah, comment from Martin. Very interesting, Peter. Evidence gaps again. His comment. This is more comment rather than question. Another one. If not, I will. Okay, I can see one more from the Angela Toperska from Macedonia. How can we enhance communication strategies between healthcare providers and patients to ensure that symptoms are taken seriously and addressed promptly, but avoiding hypochondria? Sorry if my question isn't at right place or understandable, she says.
Well, that's a really important question. It's an important question across all the screening types, isn't it? I think it seems to me with the FIT test, there are 3 possible barriers, and we don't have the research to back this up, but there's a lack of knowledge around that. There's disgust, that's something you have to overcome. Anybody has to overcome when they has to do their test. It's an unpleasant thing to do, and it's quite fiddly actually. You have to have kind of fine motor skills in order to complete it successfully. And those are 3 barriers which I think all of which may be more prominent in people with intellectual disability, perhaps. So that's not a direct answer to your question, but I think what we need is empirical data looking at the effects of those barriers and perhaps others on uptake of the test.
Okay, I hope that our colleague will be satisfied with your answer. Tria, is the paper published? Asked.
No, it's not. No, we're not. No, it's not. Actually, it's not even submitted yet. So we'll hope to do that, and we'll do that soon. And of course, we'll share it when it's done. No, it's just work we only completed about a month ago.
Okay, thank you very much. Please turn off your presentation, and now I will take the floor and also stay until the end because probably some of the participants would like to ask you something. Now I will during I will try now to start my presentation. I hope that all of you already see it. I will give the report progress on working group 4. So because I'm the leader of this group, and at the very beginning, I want to thank to all leaders of working group 1, 2, and 3 for their very good work which they done in the last year. This is one photo of our meeting in Copenhagen, March 22nd. We have very good hosts there. So I'm going to the next slide. This is the list of participants of Working Group 4. At this moment, we have around 45 participants from several European countries. Most of them are from Turkey. Turkey. What are the objectives of Working Group 4? Our working group is focused on the dissemination of the action and its activities and deliverables through a proposed designed accessible website, social media platforms such as Facebook, Twitter, blogs, open access journals, newsletters, accessible information reports, and infographics, YouTube videos as well. The Actions website and social media networks serve as the main communication channel between Action members and all relevant parties, researchers, clinicians, healthcare providers, intellectual disability organizations, advocacy groups, policymakers, screening staff, people with intellectual disabilities, and their carriers. Also, I'm very satisfied today to see approximately half of the participants today are out of our action. So there is a huge interest, I think, for our CUPID project. What are the tasks of our working group? There are 8 tasks. I will not read all of them because of the time limits. We should create an open access accessible website. We already do that, and it is updated on a daily or weekly level. Actively recruit cost action members, coordinate, facilitate, and promote exchange and mobility within partners of the action to allow scientists, early stage researchers access to healthcare organizations and academic institutions. Also, we organize webinars. This year, we organize 2 webinars on providing updates and information on key or emerging areas in CUPID action. Developing annual newsletters. We are preparing the second one. Presentation and workshops of the CUPID actions, achievements, relevant conferences, etc. This is the Gantt chart of our 4th working group, and I can say that we have done more work than it was predicted in the beginning of the grant period 2. All gray fields here are our finished tasks. What activities were done until today in this second year? We organized 2 online meetings, one in-person meeting in Copenhagen. You saw the photo. Then we organized CUPID Annual Conference, first CUPID Annual Conference in the grant period 2. It was 15th of November. We confirmed the budget for this year. Also, we organized a scientific webinar on May 10th with 5 excellent presentations and with huge interest in Europe. Also, some of us have gone on the Easy to Read training in June. It was not organized by CUPID team, but some of the CUPID team went to this training. Constantly we creating posters, posts, photos, creating also certificates for WG1 training school, which was mentioned by Dr. Denny at the beginning of today's conference in Prague. On their training school, which I will mention, it was a really good organized training school. Now we are finishing preparing the newsletter too, and I hope that our vice chair, after her presentation, probably will tell us something about that. We are planning budget for 2025. And also, I should mention that a group of authors from Serbia, led by Golubovic, Milutinovic, Simin, and Vukovic, already presented on 29th VONCA European Conference one topic: enhancing cancer prevention strategies for individuals with intellectual and developmental disabilities. This is the photo of the scientific webinar, which was realized on 10th of May. The title was Cancer Prevention in Person with Intellectual Disabilities, European Reality. And here you can see the presenters of that webinar. Probably some of you were there with us. In the first year, there was only one paper presented, and in the second year, there are 3 papers. You can see here on the screen. I will not read the names of the authors or the titles of the papers. And for the third year, we are planning at least 2 or 3 papers to be published in some relevant journals. This is the CUPID brochure, and you can find it on our website, CUPID website. So you can download it. It's for free. Also, we created easy to read CUPID brochure. It's on English, and also we translate it on Macedonian, and all project partners were asked to translate it on their languages. If one of them will translate it, we will publish it on our website. This is the newsletter which was published on June this year, number 1. And also it is downloadable free on our CUPID website. You can find there very interesting topics about our project, and you can find there one overview of the first year of our CUPID project. This is a picture from Easy Read training with Louise Todd, who delivered some of her skills, how to make easy to read presentation, posters, etc. It was realized in June, as I told. This is our website, cupidproject.eu, with 27,618 visitors. Now probably more, because this print screen is several days ago taken. Then we prepared dissemination and communication plan for our action, and it is in the PDF form, also free downloadable on the website. Then we prepared guidelines for virtual and hybrid meetings, which was distributed and with all CUPID participants. More than 200 are registered in our project, and also you can find it on our website. CUPID on the Facebook with 252 likes and 314 followers till today. I will hope that this will grow up in the third year. CUPID on LinkedIn, we are active also. Pictures, photos, activities, all announcements, you can find it on LinkedIn network, some LinkedIn statistics. Then also you can find our project activities on the other, for example, the X or Twitter, with 441 posts until today. We are following 206 people, 174. So can ask all of you to share our accounts with your friends and colleagues, and to grow up this community. We are active also in Instagram with our photos from conferences, from webinars, from web conferences, from pictures, from publishing papers, etc. 101 posts published until today with 103 followers. And also we established YouTube channel. And also afterwards you can share, please share this conference is streaming live now, and you can share the link with your colleagues if you like to do that. Next steps for the working group 4, maintaining the CUPID website, growing members of social media accounts, publishing text posters on social media, publishing texts about CUPID in newspapers, publishing newsletter at least one per year, guesting interviews about CUPID on radio and TV broadcasting programs, making easy read brochure on several languages. Next annual conference, third, probably will be in October 2025, and sending CUPID info to MPs by email and dissemination of our project. Please follow us on social media. Here are our web addresses and links. Also, I share some of them in the chat. So thank you for your attention. And if there are any questions, I'm available. One question now, and after that, on the end of the web conference, we can discuss more. This is Ohrid Lake, our Balkan Jerusalem. Thank you. Just to see. Okay, this is Peter Knapp. Thanks for your questions. I hope that you will submit the paper to a journal before the end of 2024. Okay, if there is no question for my presentation, this presentation was typically for our activities. So we will go to the next and last but not least presenter. It is Professor Jean Calleja Agius. She has also a very, very interesting presentation. So I hope that you can start, please, your presentation. She is also the vice chair of Working Group 4 and communication officer for CUPID project. Her presentation is Cervical Cancer Screening Among Persons with Intellectual Disabilities. Please start with your presentation.
Thank you very much for your kind invitation. It's been lovely hearing even the previous presenters, and I can assure you that the situation is very similar for cervical cancer. So I'm Jean Calleja Agius. I come from the University of Malta, and I also, by profession, I'm an obstetrician and gynecologist, apart from being an academic at the Department of Anatomy at the University of Malta. So cervical cancer screening among women with intellectual disabilities. So first of all, what is the state? Why is cervical screening important? So cervical cancer represents a high burden in women's health. It is well established that cervical cancer screening programs are effective in reducing morbidity and mortality. And significant progress has been made over the past years concerning screening strategies, namely the choice of screening test, its frequency, as well as the age and when to start and stop the screening. Also, it has been revolutionized through the introduction of the HPV vaccine. So if we have a look at cervical cancer screening in general in the EU, there you will see that already there is a lot of heterogeneity and a lot of variation in access to care among women in general. So in fact, only 91%, and it's not all countries, 91% have an organized national or regional screening program for cervical cancer in the EU. And of these, 45% use both cytology and testing for HPV as screening, 31% use cytology only, and 17% only perform HPV testing. So there are considerable also differences between the interval for the screening test. Some countries performing HPV detection every 3 years and others every 5 years, especially those doing the conventional cytology. And 69% of countries begin screening around the age of 25 to 29, and only 6 countries begin screening before the age of 25. And almost all countries have implemented a national HPV vaccination program, except up till last year, Poland and Turkey. And often it's the 9-valent HPV vaccine which is given. So already you can see that even, among women in general, as I said, there is variation and discrepancy among European countries in the delivery of cervical cancer screening programs. And these variations are due to organizational, economic, or cultural reasons. In fact, last year, together with colleagues from the European Board and College of Obs and Gynae, we had actually published a position paper on the importance of having a unified policy for the prevention and screening of cervical cancer, as well as other female-related cancers, such as breast cancer. So if we look at cervical cancer screening, specifically in women with intellectual disability, first of all, there isn't a lot of data out there already to start off with. But from the data that was available, that's been published to date, first of all, there is over-reporting of receipt of PEP tests. What do I mean? So if you ask a person with intellectual disability whether they've done a cervical PEP smear, and then you actually confirm with the medical records whether this has actually been done, the correlation is only for 75%. So actually 25% will tell you that they did it, but in fact they haven't done. Also, there is overall low cancer screening participation rates among women with intellectual disability, and the proportion of women with intellectual disability who are not screened are actually, even in countries like, for example, Canada, so developed countries, they are actually twice as those. So you have half the proportion of women with intellectual disability who are actually not screened. Okay, so what is shocking, even in the case of prior pregnancy. So you would think that someone who has been pregnant, in the normal, let's say, developed countries, it's the norm to offer cervical screening. But if you happen to be a woman with intellectual disability, also the uptake or the actual access to cervical pap smear is actually less, up to half. So if we were to look at the general barriers to cervical cancer screening, so irrespective of whether we are, irrespective of who you're dealing with in terms of women, so whether or not they have intellectual disability. So already cervical cancer screening, similar to colorectal cancer screening, first of all, you start with geographical barriers, with difficulty to access to services. There is also the psychosocial, so the cultural, maybe a previous negative experience, maybe sexual assault, fear of the result, embarrassment, of, having to go to your doctor to do a cervical smear test, fear of pain. Also, of course, cost, especially if there isn't a national public system for screening, time constraints, and also the lack of understanding, like the poor understanding of why it is important for cancer prevention, and also maybe because they don't feel anything, so they're asymptomatic, they don't consider it as a health priority, or they link it to menstruation. So if they have stopped menstruating, for example, they have issues with menstruation, they might not, if they have entered secondary menopause, early menopause, they might then think that cervical smear is not important. So on top of that, there are then barriers which are specific to women with intellectual disability. So first of all, their caregivers might not know or not believe that the examination is needed for their family member, maybe out of embarrassment or fear of discomfort during exams. And of course, if they don't discuss this with their family member with intellectual disability, of course, then that particular person is held back. Family caregivers themselves might lack the knowledge about the need for cervical screening by women in general, and also by women with intellectual disability. And also, the physician or the caregiver might assume that screening is unnecessary because women with ID are not sexually active. Even though, mind you, even if someone is not sexually active, they still need to do their pap smear. So, if we take a case study, this would be a case study of Mary. Mary is, of course, it's a fictitious name, but she has mild intellectual disability. She lives at home with her mother. She is 26 years old. She is sexually active, and Mary actually receives a letter inviting her to have the new cervical screening test and presents to your practice with her mother, who is her main caregiver. So it is very important, I think, in my opinion, that caregivers and physicians, all right, and healthcare practitioners know how to tackle such a situation, okay? Because already, if they have come to you for help, you need to know how would you approach the conversation with Mary about the cervical screening test. How could you support Mary in making the decision to have the screening test for herself? And how might you improve information sharing with carers? So here are some tips which really and truly, they are the same tips I would have given to any patient, really. So the strategies for building a good rapport to help to build trust. And these include being clear about your role as a physician, as a gynecologist, and the purpose of why you're there, the purpose of interaction. Using a person's preferred name when speaking with them, using a pleasant tone that is clear and precise, explaining using words and expressions that may be unfamiliar, and of course, using age-appropriate language and avoiding jargon, conveying acceptance by showing interest and concern. You speak slowly, speak directly to the person concerned, because after all, they are the central for communication. Ask one question at a time, provide adequate time for the person to process the question and answer. And if the person is using a communication device, ensure they have access to it, and also read the directions so that you can actually use it with them. And it is necessary, while it is necessary to, while in certain cases it's necessary to get history from the carer, including possibly sexual history, it is important to keep the focus on the person with a disability, through your eye contact and body language. So, just to conclude, what are enablers for cervical cancer screening, especially in women with intellectual disability? They're actually quite common sense. You start by increasing the knowledge to caregivers on the importance of cancer screening, particularly cervical cancer screening. Increasing the knowledge and the importance of cervical screening also to women with intellectual disability. Increase the accessibility to screening to all women, especially even women with intellectual disability. We know that, as Professor McMahon said, they are at increased risk of cancer in general and increased risk, including of cervical cancer. And it is important to adapt the national screening program, if it is present, accordingly in order to ensure equity. So thank you very much. You are more than welcome to come and visit us at our university, University of Malta. And please, if you have any questions, go ahead.
Yeah, great lecture, Professor Jean. It's my pleasure. It was my pleasure to hear you. And thank you for inviting us to visit your university. Probably we can talk on our next meeting, could be there. If the majority of the CUPID members agree on that. There is one question from Irena Stoyanovska from Macedonia. As you noted, the available data mainly originate from developed high-income countries. Can you possibly estimate the extensive differences in screening rates and outcomes compared to middle and low-income countries?
Yes, thank you for the question. Excellent. Actually, I have been chairing another co-section called Gynocare, where we were specifically looking at screening rates, particularly of cervical screening rates, across Europe and even beyond. And you are very right. There is already, I mean, in Europe, within Europe, for example, if you compare Eastern Europe, like the Balkans, and the rest of Europe, there is already a discrepancy in the uptake of cervical screening. And of course, if you compare to other countries, there are actually countries with an inexistent screening program, cervical screening program. So yes, I mean, in that case, not even in women without intellectual disability do you have good data, let alone in women with intellectual disability. So yes, and similar to colorectal, I mean, but probably with cervical, it's even worse because it's going to affect women, so already, they might not, I mean, women from poorer countries might not be as comfortable or have as much access to do their smear. So even women in general, let alone women with intellectual disabilities.
Yes, that's right, especially your last sentence, because I'm coming from low to middle income country. Now I will ask all the speakers if they want to turn on their cameras, and we can start some discussion. We have 5-10 minutes more. I cannot see any other questions in the chat. If there are no, I will go to close, but I will ask my younger colleagues to make one group photo with the speakers, and also if Francois and Florian, who are giving our technical support, IT support, or this web conference, if they want to be on the picture, also because they're a part of us, they can turn on the camera. I'm still expecting questions from the audience, or also from you, if you want to ask someone from us something, because all of you are the working group leaders, or to announce something regarding the grant period 3, you can take the floor, please. Okay, nobody. Now, Professor Peter Knapp raised the hand. Please go on.
Thank you. It was just to pick up on the last presentation about cervical screening, and I wonder whether the opportunity to use vaccination as a way of preventing cancer may help to overcome some of the barriers, whether they're cultural or financial or practical, that have been experienced with other kind of cancer screening methods. Something that's perhaps cheaper and less invasive and less embarrassing. Yeah.
Definitely. In fact, I mean, in most developed countries now, I mean, cervical vaccination, HPV vaccination is offered to girls and boys at age 12 most of the time. So yes, there's definitely is a good solution. Yeah. And in fact, I mean, overall, although cervical cancer is still a reality, but overall, the trends are going down. And in some countries where they have instituted cervical HPV vaccination, like for example in Malta, actually we consider cervical cancer nowadays as a rare disease, as a rare cancer. So
and it might reduce the gap between the general population and people with learning disabilities if you have a procedure that's less difficult for whatever reason, that it may increase equity.
Yes, definitely.
Okay, thank you both of you. One more question or comment from Elif Sarac. I would like to thank all presenters. Martin's and his colleague study really took my attention. You have started in your paper that this study will help to reach marginalized groups. I'm asking, as a public health professional, do you have any kind of intervention strategies related to these findings in Ireland for this vulnerable group? Thank you. Martin, just a quick answer and then you can go.
No, look at the answer is no. I think the challenge we face identifying people with an intellectual disability, as we only identify people who've got more severe, profound intellectual disabilities who are known to service providers. So any intervention needs to be at a population level where there is the concept of like fairness, that is, are the interventions that we are putting in place at a population level, are they going to meet the needs of people who have got intellectual disabilities? So we typically only know less than 40 in Ireland, for example. I know the UK is the same. Less than 40% of people with an intellectual disability will be known to any services. So we typically undertake research and put in interventions for people who are known to services, but there is a majority of people who aren't known. So we really need to look at the population level, and whatever interventions are implemented at the population level, they need to be reflective of the needs of people with an intellectual disability, considering UNCRPD and access, so accessibility, Article 9, and healthcare, Article 25.
Okay, thank you for your answer. I hope that Elif will be satisfied. Martin should go. And I cannot see on any other raised hands, and no more questions in the chat. So I can go to close this web conference. We are in the time frame. We planned 75 minutes and we are in time. So let me to thank, first of all, to all speakers for this wonderful conference and wonderful presentations from them. Also to thank all 56 participants who have been today with us and who spent a little time from their time to listen.